Welcome to Roadmap to Residency. Today we are breaking down Anticoagulation Management for the United States Medical Licensing Examination Step 2. This is not a lecture. This is a strategy session. We are going to walk through high-yield question stems, teach you test-taking tricks, and show you exactly how the board writers try to trip you up. If you are studying for boards, make sure to like this video, subscribe to our channel, and visit roadmaptoresidency.com for expert tutors and residency advisors. Let us jump right in. Here are our learning objectives for this session. We want you to walk away being able to recognize the classic question stems for Warfarin management and reversal scenarios. You need to know when and how to reverse each anticoagulant. You should be able to distinguish between heparin-induced thrombocytopenia and other causes of low platelets in a hospitalized patient. And critically, you need to master perioperative bridging decisions, because these show up constantly on board exams. For the foundational knowledge, go to your board review resources and look at the anticoagulation chapters. We are here to teach you how to answer the questions, not to reteach the pharmacology. Before we dive into cases, let me give you the framework you should use every single time you see an anticoagulation question on the exam. First, identify which anticoagulant the patient is on. Is it warfarin, a direct oral anticoagulant, unfractionated heparin, or low molecular weight heparin? Second, determine the clinical scenario. Are they bleeding? Is the international normalized ratio supratherapeutic? Are they going to surgery? Do they have a new clot? Third, match the reversal agent or management strategy to the specific drug. This three-step approach will get you through nearly every anticoagulation question on the exam. Your board review books cover this framework in the hematology and pharmacology sections. Let us talk about the buzzword associations that the board loves to test with warfarin. When you see a patient on warfarin with an elevated international normalized ratio and no bleeding, think hold warfarin and consider vitamin K by mouth. When the stem says serious or life-threatening bleeding with an elevated international normalized ratio, the answer is 4-factor Prothrombin Complex Concentrate plus intravenous vitamin K. Fresh frozen plasma is the older answer, but 4-factor Prothrombin Complex Concentrate is now preferred because it works faster and does not require large volume infusions. And when you see skin necrosis in the first few days of starting warfarin, think protein C deficiency. This is a classic board question. These associations are covered in detail in your hematology and pharmacology review materials. Here is our first case. Read this stem carefully. A 72-year-old woman on warfarin for atrial fibrillation presents to the emergency department after a fall. She has a large scalp laceration that is actively bleeding. Her international normalized ratio comes back at 8.5. She is alert and oriented. Blood pressure is stable. The question asks, what is the most appropriate next step in management? The answer choices are A. Hold warfarin and recheck the international normalized ratio tomorrow. B. Administer fresh frozen plasma. C. Administer 4-factor Prothrombin Complex Concentrate and intravenous vitamin K. Or D. Give oral vitamin K only. Think about this before we go to the next slide. Let us walk through this question. The correct answer is C, 4-factor Prothrombin Complex Concentrate plus intravenous vitamin K. Here is why. First, analyze the clues. She is actively bleeding. The international normalized ratio is dangerously elevated at 8.5. She is on warfarin. This is a serious bleed. Now eliminate the wrong answers. Choice A, just holding warfarin, is wrong because she is actively bleeding. You cannot wait. Choice B, fresh frozen plasma alone, is not the best answer anymore. It takes time to thaw, requires large volumes, and 4-factor Prothrombin Complex Concentrate is the current standard of care. Choice D, oral vitamin K alone, takes 12 to 24 hours to work. She is bleeding now. The test-taking strategy here is simple. Active bleeding plus supratherapeutic international normalized ratio equals emergent reversal. 4-factor Prothrombin Complex Concentrate is faster than fresh frozen plasma. Always give vitamin K alongside it for sustained reversal. Review the warfarin reversal algorithms in your board prep resources. Now let us shift to the direct oral anticoagulants. These are Dabigatran, Rivaroxaban, and Apixaban. The boards love these because the reversal strategies are newer and more specific. Here is what you absolutely must know. Dabigatran is a direct thrombin inhibitor. Its specific reversal agent is Idarucizumab. Rivaroxaban and Apixaban are both factor Xa inhibitors. Their reversal agent is Andexanet Alfa. The key test-taking pearl is this. The boards will try to trick you by offering 4-factor Prothrombin Complex Concentrate as the answer for direct oral anticoagulant reversal. While it can be used if the specific reversal agent is not available, the best answer when a specific agent is listed is always the specific agent, Idarucizumab for Dabigatran, Andexanet Alfa for factor 10A inhibitors. Also remember that unlike Warfarin, routine monitoring with the international normalized ratio or the partial thromboplastin time is not recommended for direct oral anticoagulants. Your pharmacology resources cover the mechanism details. Case 2. A 65-year-old man on Dabigatran for atrial fibrillation is brought in after a motor vehicle accident. He has a large retroperitoneal hemorrhage on imaging. His blood pressure is dropping and he is tachycardic. The question asks, what is the most appropriate agent to reverse his anticoagulation? The choices are A. Vitamin K, B. Fresh frozen plasma, C. Idarucizumab, or D. Andexanet Alfa. Take a moment and think about which drug he is on and what reverses it specifically. The correct answer is C. Idarucizumab. Let us break this down. The patient is on Dabigatran, which is a direct thrombin inhibitor. He has life-threatening bleeding. You need the specific reversal agent. Idarucizumab is a monoclonal antibody fragment that binds Dabigatran directly and neutralizes it within minutes. Why are the other choices wrong? Choice A, vitamin K, only works for warfarin. It has no effect on direct oral anticoagulants. This is a classic distractor. Choice B, fresh frozen plasma, replaces clotting factors, but does not directly counteract Dabigatran. It is not the best choice when Idarucizumab is available. Choice D, Andexanet Alfa, reverses the factor 10A inhibitors like Rivaroxaban and Apixaban, not Dabigatran. The board writers love swapping the reversal agents to see if you know which goes with which. Remember, Dabigatran equals Idarucizumab. Factor 10A inhibitors equal Andexanet Alfa. Check your pharmacology section for complete reversal protocols. Now let us cover heparin and low molecular weight heparin. Unfractionated heparin is monitored with the activated partial thromboplastin time. Low molecular weight heparin, like enoxaparin, is monitored with antifactor 10A levels when monitoring is needed, though routine monitoring is typically not required. The reversal agent for unfractionated heparin is protamine sulfate, and it works very well. For low molecular weight heparin, protamine only partially reverses it, roughly 60%. The board loves to test the complication of heparin-induced thrombocytopenia. This is a prothrombotic condition, not a bleeding condition. The platelet count drops, but paradoxically the patient forms clots. The classic board presentation is a patient who has been on heparin for 5 to 10 days and develops a 50% drop in platelets with a new clot. These details are thoroughly covered in the hematology section of your review resources. Case 3. A 58-year-old woman is 7 days post-operative from a hip replacement and has been receiving subcutaneous unfractionated heparin for deep vein thrombosis prophylaxis. Her platelet count was normal on admission, but today it is 70,000, down from 160,000 3 days ago. She also has a new, swollen, painful left leg. The question asks, what is the most appropriate next step in management? The choices are A. Continue heparin and monitor platelets. B. Stop all heparin products and start argatrobin. C. Transfuse platelets. Or D. Switch to low molecular weight heparin. Think carefully about the timeline and the clinical picture. The correct answer is B. Stop all heparin products and start argatrobin. This is a classic heparin-induced thrombocytopenia presentation. Let us analyze the clues. The timing is perfect, 5 to 10 days after starting heparin. The platelet drop is greater than 50% from baseline. And here is the critical clue. She has a new deep vein thrombosis. Heparin-induced thrombocytopenia is a prothrombotic state. Why are the other choices wrong? Choice A, continuing heparin, would be dangerous. You must stop all heparin immediately. Choice C, transfusing platelets, can actually worsen thrombosis in heparin-induced thrombocytopenia. This is a classic trap answer. Choice D, Switching to low molecular weight heparin is wrong because low molecular weight heparin can cross-react with heparin-induced thrombocytopenia antibodies. You must use a non-heparin anticoagulant like argatroban or bivalirudin. The test-taking strategy. When you see dropping platelets plus new clot plus heparin exposure, the answer is always stop heparin and start an alternative anticoagulant. Your hematology review sections cover the 4T score for calculating pretest probability. Perioperative anticoagulation management is one of the most commonly tested topics on the exam. The key question the board asks is, when do you bridge, and when do you just hold the anticoagulant? Here is the framework. For warfarin, the decision depends on the patient's thrombotic risk. High-risk patients, like those with mechanical mitral valves or recent stroke, need bridging with low molecular weight heparin or unfractionated heparin. Low-risk patients, like those with atrial fibrillation and a low stroke risk score, can simply stop warfarin 5 days before surgery and restart afterward. For the direct oral anticoagulants, the situation is simpler. These drugs have short half-lives, so you typically just hold them 1 to 2 days before surgery depending on renal function and bleeding risk. Bridging is generally not needed for direct oral anticoagulants. This is a high-yield distinction the exam loves to test. Review the perioperative medicine and cardiology sections of your board prep materials for the complete bridging algorithms. Case 4. A 68-year-old man with a mechanical aortic valve on warfarin needs an elective total knee replacement in 2 weeks. His surgeon asks about perioperative anticoagulation management. His international normalized ratio is currently 2.5. The question asks, what is the most appropriate perioperative anticoagulation plan? The choices are A. Continue warfarin through surgery. B. Stop warfarin 5 days before surgery with no bridging. C. Stop warfarin 5 days before surgery and bridge with low molecular weight heparin. Or D. Switch to Apixaban 2 weeks before surgery. Think about his thrombotic risk given his mechanical valve. The correct answer is C. Stop warfarin 5 days before surgery and bridge with low molecular weight heparin. Here is the reasoning. The patient has a mechanical heart valve. This puts him in the high thrombotic risk category. Patients with mechanical valves, especially mitral valves, are at significant risk for valve thrombosis and stroke if anticoagulation is interrupted without bridging. Why are the other choices wrong? Choice A. Continuing warfarin through surgery would cause dangerous surgical bleeding. Choice B, stopping without bridging, would be acceptable for a low-risk patient, but a mechanical valve is high risk. Choice D, switching to a direct oral anticoagulant, is wrong because direct oral anticoagulants are contraindicated in patients with mechanical heart valves. This is an extremely high-yield fact. The boards test this frequently. The test-taking strategy. Whenever you see a mechanical valve, think high risk, think bridging is needed, and remember that direct oral anticoagulants are never the answer for mechanical valves. Your cardiology and perioperative medicine sections have the complete risk stratification tables. Let us do a quick final review of the highest yield points from this session. For warfarin reversal with serious bleeding, the answer is 4-factor Prothrombin Complex Concentrate plus intravenous vitamin K. For Dabigatran, the reversal agent is Idarucizumab. For Rivaroxaban and Apixaban, it is Andexanet Alfa. For Heparin-Induced Thrombocytopenia, stop all heparin and start argatroban. Never transfuse platelets in heparin-induced thrombocytopenia. For perioperative management, bridge high-risk patients on warfarin. Do not bridge patients on direct oral anticoagulants. And never use direct oral anticoagulants in mechanical valve patients. If you found this video helpful, please hit the like button and subscribe to our channel. For one-on-one tutoring and residency advising, visit us at roadmaptoresidency.com. Our expert tutors and residency advisors are ready to help you crush your boards and match into the residency of your dreams. Good luck studying, and we will see you in the next video.